Thank you, and thank you to our panel today. I got a question. I think it's for Dr. Lowy, but whoever can answer it, I'd be happy to hear from you. My question really has to do with patient navigator programs, which help low-income patients and those in underserved communities access early screening, diagnosis, and treatment. And I want specifically in terms of cancer. Can you tell me how the Cancer Moonshot program will invest in patient navigator services to ensure access to any of the new treatment?
Congresswoman, thanks for this question. Patient navigation is one of several aspects of trying to provide optimal treatment for patients with cancer, which has become much more complicated in recent years, in part because of its success. In terms of approval of patient navigation, this is beyond the NIH, but we conduct implementation research to try to optimize patient navigation, along with many other aspects of trying to help people have appropriate and full access to cancer care. This includes doing patient care at home, changing radiotherapy, for example, shortening the duration of radiotherapy, and trying to look at patient navigation in the context of this real overall issue of how to provide optimal care to virtually everyone in the United States who is unfortunate enough to develop cancer.
Well, thank you, and I hope you will work closely with whatever agency it is that directs the navigators, because obviously you can have all kinds of new developments, but if we're not able to get it, to the full population, I think we'll be missing a lot.
Thank you.
And I want to ask you, so let me ask this question in terms of research on something sort of basic. I think everybody I have ever met in my life, and you hear about this on TV, all kinds of diets, and there's fad diets, and then you read about, especially in underserved communities where people are not even getting access to the nutrition that they need. What kind of research is being done in that regard in terms of dieting and access to food for everyone?
So we have recently launched a new set of initiatives in nutrition. Among them is a study of so-called food deserts, where inadequate nutritional foods are available within a given neighborhood. And part of this research will be focused on how one can, redress that in the best way possible. Other areas of research have been powered by advances in analytical technology. Just as you have the human genome and the human proteome, you also have the human metabolome. And the metabolome is really a reflection of your nutritional state. And so we now can study things at the molecular level to give great insight into the value or not of various nutritional agents. So we are doing this from both the community-based level all the way to the molecular level.
All right. Well, at some point, I would love to just get some information on that. And then I know tomorrow we're going to be talking about, or this week, on elderly issues that affect our elderly. One is falls. But I do have a research question. The healthcare system it's costing us over $50 billion annually on falls for older people. 36 million older adults report falls every year. I'm sure it's much more than that. We heard about technology to monitor falls in older adults and habits that can change to reduce their falls. Is there a timeline for these products? Can you explain what they are, these products to monitor falls? Is anyone on this panel aware of that?
Yeah, so through the National Institute of Aging Their SBIR, Small Business Program, has made several awards. For example, they've supported a small company, Biosensics, that has developed something known as Active PERS, which is a medical alert pendant that does do automatic fall detection. And this has now been licensed and integrated into medical devices broadly, and it is available through a variety of mass market retailers. But they are supporting additional research to develop sensors, for example, that detect floor vibrations, which could be very valuable, obviously, for those who are hospitalized or otherwise infirm.
Okay, thank you, and I yield back.